Thanks. It's my pleasure to introduce you to our opening speaker, Dr. Laura Gottlieb. Dr. Gottlieb is a family physician and the founding director of SIREN, which is the Social Interventions Research and Evaluation Network at the University of California, San Francisco. If you're interested in this space, get on their listserv. They publish outstanding research and lots of information about the intersection between medical care and social care. And with that, I will turn it over to Dr. Gottlieb. Thank you for joining us here in Texas.
Oh, it is absolutely my pleasure. And I will say, Zoom makes it a lot easier. I'm so happy to be here. So I think Eileen is gonna let me share my screen. So give me one moment while I set this up. So can someone just confirm that you're seeing my slides? Is that right?
Yes. Yes.
Yes.
Okay, terrific. Well, Elena, thanks again for the introduction. I also really appreciate the plug for SIREN. So the Social Interventions Research and Evaluation Network is really focused on supporting the synthesis and dissemination of evidence on ways that the healthcare sector can better engage around social determinants, data, and interventions to improve health and health equity, particularly for low-income and otherwise disenfranchised populations. You could see why I would be delighted to be here helping to kick off this 2 half-day event. And I'm really grateful to Eileen and Elena and the Episcopal Health Foundation for including me. It will come certainly as no surprise to the people assembled here that social determinants of health are in vogue in the U.S. healthcare sector. So questions about the sector's social care roles and responsibilities have become a central focus not only of healthcare-based reports, papers, and conferences, but also many recent clinical innovations and payment models. But even in the context of those signs of accelerating interest, we haven't yet been successful at taking clinical social determinants of health work to scale. And I think that that's part of what the conversation is going to be about over the next couple of days. That said, enter COVID, which of course accelerated interest and innovation in this area by underscoring the very powerful and very devastating intersections of health and social adversity. So in the acute pandemic setting, we've seen changes in the acceptability of screening and interventions in very short order. So for instance, we've seen more attention to screening for homelessness as a strategy to improve virus containment. We've seen many communities rapidly develop temporary shelters that healthcare providers are utilizing for high-risk patients. We've seen an expansion of screening to child care and digital access. We've seen broader food coverage interventions and other changes in healthcare activities. But a key question is whether we would be able to and interested in sustaining this level of activity in the context of the longer-term poverty pandemic that is developing now. So at this moment in time, it just feels really important to recognize that the heightened attention to social adversity is in some ways just indicating that we're at the beginning of what in technology startup language, and remember, I'm from California and Northern California at that, so this is a particularly appropriate slide for me to use. What we call in technology startup language or refer to as an innovation hype cycle. So the first phase of that cycle typically involves a peak of inflated expectations where early publicity produces many success stories. But unfortunately, that peak is often followed by a trough of disillusionment where early innovations don't consistently deliver. So while the healthcare sector's activities around social determinants certainly won't ever fix everything that ails the US healthcare system or that causes health inequities, our goal at Siren is to maximize their possible impact. And we do that by trying to make this trough of disillusionment a little less deep and increase the slope of enlightenment so that we can find some innovations that work. So in my role at Siren, I had the privilege of serving on a recent National Academy of Medicine committee that was designed specifically to explore how the healthcare sector is and could be working at this intersection of social and medical care to improve health. And today, Eileen asked me to just share findings from the committee's process, which centered on developing a 5-part framework that describes the range of ways that healthcare systems are engaging around social determinants. And I'm hopeful that sharing this language and definition from the committee's process could help in the series of conversations you have planned, and moreover, beyond these 2 days as you continue to explore ways to do this work in Texas over time. So I'll just jump right in. The National Academy proposed a framework that defines 5 different ways that the healthcare sector is already providing and could strengthen social care and social conditions to improve health. And the first category, furthest to the left of these activities, describes strategies being used to simply increase our awareness of patients' social conditions by identifying social risks and assets of defined patients and populations. And then the other 4 categories listed here really are about interventions, both healthcare delivery or patient-focused interventions, and then the latter 2 are more focused on community interventions. And I'm going to march through this framework over the rest of my talk. So just starting in the awareness bucket. Again, these are strategies that healthcare systems are using to collect information about patients' social conditions. This includes a diverse set of initiatives, including those where patients are just being asked about social risks in clinical settings, or sometimes in health risk assessments conducted by insurers. But there are also systems that are buying big consumer data about purchasing history, home ownership, or bankruptcy. And then there are other systems that are mapping area level or neighborhood level socioeconomic data and crossing those with patient addresses and bringing them into electronic health records. At the patient level, or individual patient level, much of the research happening around social risk awareness has revolved around these new social risk screening tools that have been endorsed by groups like the National Academy, CMS, and the National Association of Community Health Centers. There are others, though. And as many of you know, there's actually been kind of a vexing lack of consistency in these tools, which don't always include the same social domains or even the same measures in similar domains. They also vary a lot in length. You can see the length and some of the topics covered in 3 of those major screening tools that I mentioned on this slide. And then the sideways reference from our website will take you to a list of some of the other common screening tools being used in this space. Unfortunately, the differences in the ways that information is being captured, the measures that are being used, makes it so that the data captured are not consistently aggregable across healthcare settings. Of these tools, colleagues of ours in Seattle and Portland have demonstrated that none of them has actually followed the ideal steps in gold standard measure development, which typically involves a sort of 8-step process. So in general, people are just pulling together measures on specific social risk domains and putting them into a shared tool. I will say, though, that the content and validity of the measures don't seem, that it is important to note that the content and validity of measures don't seem to affect patients and families' reactions to these tools, the majority of whom report feeling relatively comfortable being asked about social risk screening in clinical settings. So here I'm showing the results of a 1,000-person survey that our team did, including 10 different clinical sites around the country, including 4 pediatric settings, 2 primary care, 2 emergency room, and 6 adult medicine settings, also with a split between primary care and emergency rooms, where we asked patients about whether they considered it appropriate to be asked about social risks in healthcare settings, and moreover, how comfortable they were with that data on social risk being incorporated into their electronic health records. So you can see from these pie charts that the majority of people are either very or somewhat comfortable with both. So given that the tools exist and are increasingly being incorporated into electronic health records and generally pretty acceptable to patients, we might then wonder about the extent to which social risk screening is already happening in healthcare organizations around the country. So this is a slide from my colleague Teresa Fraze, who analyzed findings from a national survey of healthcare organizations, including hospitals and outpatient practices. Respondents indicated that the majority were already routinely screening patients for at least one social risk factor, and somewhere around 20% reported screening for all 5 social risk factors included in the CMS screening tool, which includes topics related to housing, food, utilities, transportation, and interpersonal violence. But what's curious about this is that the extent to which screening is really happening is a little less clear. For instance, if you ask patients directly about whether or not they've been asked about or assisted with any of these topics, the numbers reported by the hospital and clinical leaders indicate that there might be some inflation. And it turns out that if you actually look at the surveys that have been done with hospital leaders, et cetera, most of those are not indicating any denominator. So they might say that they're doing it, but that might indicate, that might represent that they're doing it with a select or targeted population. So we are starting to understand that there are facilitators for social risk screening, and certainly technology is one of them. So as I noted, many of these tools are being incorporated into major electronic health record vendor platforms. Some individual health systems are just incorporating these kinds of questions. And that way, the information about social risks is then available to clinicians at the point of care. This is a slide from the OCHAN electronic health record. Payment incentives also are being used to increase screening adoption. So this is a slide from a private payer who incorporated social risk screening as a reimbursable quality measure. And we're seeing that happen increasingly among both private payers and state Medicaid agencies. So I want to move on to the rest of the National Academy framework now, which really focuses not only, again, on how we identify social risks, but probably more importantly, what healthcare systems can do with that information. So as I mentioned earlier, the first 2 of these are more clinical delivery system or patient focused, and the second are more about community targeted strategies. The first of the patient focused strategies refers to situations in which social risk data are being used to inform clinical care decisions. So the committee referred to these as adjustment strategies. These can be right at the point of care or at the payment level. So for instance, we might choose in the course of clinical care a less expensive medicine, or we might adjust quality measure payments based on social risk factors. There's a lot of discussion about this right now at the policy level. But truthfully, I like to think that this adjustment work is stuff that as providers, particularly in the safety net, we do every day. We just don't always do it well or systematically. So for instance, we accommodate social factors that could interfere with medical treatment. We try to improve access to care for patients who don't have great access. We send out mobile vans. We have evening and weekend clinics. We provide interpreters. We provide low literacy materials. We also use social data to inform diagnostics. So for instance, the mini mental status is supposed to be adjusted for literacy level. And finally, we adjust our treatment plans based on social risks. We might dose once daily meds to accommodate work schedules. We won't prescribe a CPAP machine for a patient living in a shelter or loop diuretics to patients who have hypertension but don't have regular access to bathrooms. So a common example I use around adjustment is from a clinic that provides overnight dialysis appointments in an effort to improve adherence for homeless patients. So there is some exciting work coming out around social risk informed or adjusted diabetes care from folks like Tiffany Vano in Michigan and Danielle Hessler, my colleague at UCSF. So this slide comes from work Vano's team did, exploring the different ways in which providers caring for patients with diabetes endorse changing care based on information about patients' social risk factors. They do things like change target blood sugar goals. They do more cost-sensitive prescribing and otherwise make significant changes to guideline concordant care. So like the other activities in the National Academy framework, adjustment strategies can be facilitated by payment and technology support. I won't go into the details of those, but certainly we can talk about them during the discussion if it's of interest. What I want to spend the majority of the rest of my time on, though, is on these assistance strategies. So these are, again, a patient-focused strategy that is especially common in the news and now health services research. And I know you will spend a lot of time talking on in the next couple of days. These are point-of-care interventions that more directly intervene on social needs. So by and large, these are interventions where we actually leverage the healthcare system's resources in some way to improve patients' social context. And just as an example, so instead of using or prescribing non-refrigerated medications, which would be an adjustment strategy, we might actually help the patient get a refrigerator. So in this example, maybe we would connect patients with food programs like they're doing for every hospitalized patient at ProMedica in Ohio and Michigan, or help patients obtain a living wage job like they're doing at Roots Community Health Center in Oakland. Here in California, under our 1115 waiver, we're paying for housing support specialists to help patients who have housing instability actually find a home. So these interventions, like in the case of adjustment, are sometimes part of care, but rarely routinely or systematically built into practice. So as with awareness and adjustment, data and technology are driving assistance interventions increasingly. And in fact, an entire new technology industry has emerged to help bridge medical and social care referrals. And as you all know, some of those tech startups actually started there in Texas. But there's a big unknown here about whether the availability of data, including the referral information or information fed back to healthcare organizations through closed loop referrals, actually improves health. So to set the backdrop for your conversations this afternoon and tomorrow, I'm just going to highlight a few promising studies on assistance interventions and then underscore some of the related evidence gaps that could be the focus of future research. So there have been a handful of high-quality experimental studies with either actual or synthetic control groups in both adults and in pediatrics that have shown some positive impacts of assistance interventions. Impacts that include improvements in health and reductions in cost. So this study by Seth Berkowitz's team examined the impacts of a low-intensity, volunteer-led navigation program and found significant reductions in participants' blood pressure and cholesterol. Another study by the same team showed that medically tailored food boxes led to reductions in readmissions and healthcare costs for Medicare and Medicaid beneficiaries. Other interesting work relevant to this topic comes from Shreya Kangovi's team, which is focused on the impact of community health workers. So she recently published a really interesting return on investment analysis based on an RCT trial of her IMPACT program. IMPACT is a standardized community health worker intervention that addresses patients' unmet social needs. So in that study, they found that every dollar invested in the intervention would return $2.50 to an average Medicaid payer within the fiscal year. I'm also going to highlight some of the work our own team has done in pediatrics. So in these studies, we compared the effectiveness of handing a family a sheet of written resources about community programs versus providing one-on-one personal assistance in accessing these programs. The upshot of these studies is, like in adult populations, we are starting to see that these programs can improve health and reduce costs. But despite these early studies, there certainly are ongoing evidence gaps in what we know about these intervention approaches. And I'm just going to summarize those. I think Eileen also did a really good job at posing some of these key questions in the background materials, but I'm hoping that we can sort of dive into some of these in the discussion session too. So the first that I've highlighted here is, what are the most effective and cost-effective interventions and strategies? So for instance, is it more effective and cost-effective to target some social risks than others? Second, do social needs interventions, could they have negative unintended consequences, like for specific populations? What are the impacts on health equity? So is it possible that these individual level interventions could perpetuate some of the structural inequities or perpetuate the white supremacist systems in which they sit? And certainly answering these questions will require more comprehensively understanding the mechanisms that underlie effective interventions and that maximize practitioners' ability to tailor interventions. And then finally, I'll just say that a big outstanding question is, what do we need to actually scale effective interventions? So what are the payment and quality incentives? What is the technology and data infrastructure? And what are the workforce innovations that we need to put them into practice? So before closing, I do want to just mention the community-focused strategies. It was here that the committee really underscored how important community-level efforts are to address social conditions, and that the healthcare sector could be a strong ally and advocate for that work. Alignment and investment activities are activities undertaken by healthcare systems to understand existing social care assets and to help facilitate synergies between healthcare sector actions and community level actions, including by investing in them to positively affect health outcomes. And then advocacy activities are instances where healthcare organizations are working with their partners to promote policies and facilitate either the creation or redeployment of assets to improve social conditions. So I will throw up here a slide that just summarizes the 5-part framework. This is showing how a topic like food insecurity could be addressed in this range of complementary ways using the 5-part framework. But if we're lucky, I'm hoping that maybe Keegan, who I know is presenting later, will share a slide that she created that applies the same framework to a topic like the public charge rule. I don't think I'll walk through it for the sake of spending more time on this question or the discussion session. So that is really my very high level overview of what's happening in the space. I did want to share information just about the network, which I hope can serve as an ongoing resource for those of you who are interested in learning more or doing more in this area. We are housed at UCSF and funded by Kaiser and Robert Wood Johnson Foundation. Again, our goal is just to generate more high quality evidence in the area, or in this field, but then mostly put it in the hands of people who can use it. So all of our materials are freely available. We have a pretty comprehensive evidence library that is easily searchable, and we would really welcome more users from Texas. So please don't hesitate to check out our site. So I will stop there, and hopefully we can just turn it over to questions. I may end my slideshow, and then we can just sort of have a face-to-face. Eileen, does that sound okay?
Yeah, that's perfect. Thanks, Dr. Gottlieb. And Elena Marks is going to facilitate a little Q&A. And if people want to raise their hands to ask questions, you are welcome to do that at any time.
I don't see hand raises. I'm looking in the chat. Am I looking in the wrong place, Eileen?
No,
Will Carey has a question.
You look at the
Please
participants
ask.
list.
That's
Oh,
right.
okay. Let me open up the participants list. Okay, Will Terry from HHSC, please ask.
Oh, thanks. I really enjoyed the presentation, and I wanted to ask your opinion about some of the screener information. I've been looking at different standardized screeners that have been used across different social determinant of health intervention strategies, and I was curious about your interpretation of using standardized screeners versus using some of the ICD-10 diagnostic codes, the Z codes as they're called. Do you see that, or do you think that the Z codes have any benefit as a standardized screening tool, or are you leaning more towards some of the tools that have been developed or developing a whole new tool in general?
It's an interesting question. Well, I probably would answer that by saying that those are apples and oranges, and I'll explain why I think that. But I think it is a really interesting question. So the screening tools are actually, they're posing specific questions. So for instance, they include questions specific to, over the last 12 months, have you had difficulty making ends meet at the end of the month? The ICD-10 codes don't tell you what to ask. They give you a diagnosis, and then you include the diagnosis. So you might tie the diagnosis codes to people's responses in the social risk screening tools, but you wouldn't know what to ask if you were using the ICD code. And it turns out that the code development has been pretty divorced from the development of validated screening tools. So we're not really sure which tool should count when you pick an ICD code, even if you were to diagnose it. So we actually have been working to develop this sort of national consortium of people who are trying to standardize the medical vocabularies like ICD-10, but also LOINC and SNOMED and CPT, so that they better reflect all the activities that people are undertaking in clinical settings related to social conditions. So for instance, it would be really nice if we had a code that was, well, I screened for food insecurity. We'll just pick a particular topic. I screened for food insecurity, not just I diagnosed food insecurity, which is what ICD would do. Does that make sense?
Yes, that does make a lot of sense, and that I appreciate that your insight and feedback on that question.
Is there another question? Otherwise, I'm throwing one out at you, Laura.
Uh-oh.
Well, this is on the technology side, and you showed a page with all of the various tools that are out there, some of which we know developed in Texas, like Tab Health and Aunt Bertha. What is going on with the integration between those tools, EMRs, and health information exchanges? Are we adding another layer, or are these intended to be integrated? How does all of that, where are you seeing it work well, and how does that look?
It is such a complicated question, as you know. So the work that we did for you and Xiaoqi really tried to unpack some of the topics that you're raising here, Alina. And for those who are interested, I would encourage you to check out the work that Yuri Cartier and Caroline Fichtenberg led from our team that is really trying to explore the experiences of early adopters and just generally the functionalities of these platforms. I'll say that I think the intention of everybody who has been involved in developing those platforms and in using those platforms has been this like seamless integration, right? Like people want these to be incorporated into electronic health records. They want it to be so easy from the point of care to both make referrals and then pull it back into the electronic health record and make it so that there's that this social care platform is part of a health information exchange. But the reality hasn't yet looked like that. There are very few, if any, that have actually created a way to incorporate the technology into the electronic health record in a way that isn't super cumbersome. Everybody talks about wanting to create a closed loop referral, but that is hasn't yet become a reality. And it's not for lack of trying. I mean, I think that people are really trying to do this, but it hasn't yet come to fruition. I will say that just in the COVID era, sites that had these technology platforms in place said that they were using them and they were using them more, that people really appreciated having that information available, even if they had to log into a separate system in order to access the information, that the urgency with which people have adopted some social risk screening and referrals made it easier when they had that information at hand. And places that hadn't yet implemented those programs were frustrated or disappointed that they hadn't yet put them into place. I hope that's helpful.
Yes. Is there a question from the participants? Otherwise, I'm going to throw out another one.
Please don't. Somebody ask a question. Elena's scary.
Well, this is an even harder one. I want you to get out your crystal ball and considering COVID and all that it has shown about not just who gets sick and die, but the fact that some people are getting sicker and are dying at higher rates than others has elevated issues that those of us who live in the public health, social justice, social determinants world have thought about for a long time. How do you see that when we reinvent the system, because we will be reinventing the system? Are we going to have more emphasis on pre-healthcare system work, or is the healthcare system going to get enhanced so that it can take care of even more sick people?
I'm gonna answer that in a little bit of a different way. That is, maybe you'll call me on it. I'm not sure, but I think what we're seeing, not just with COVID, but with sort of our national reckoning on race and racism, is that these 5 strategies for the healthcare sector's roles and responsibilities can't be singular. You can't pick one and run with it. My response would be that the healthcare sector can play a really important role in across the spectrum. And the way I will tie it back to your question, Elena, is that I think that means we have a really important role to play, probably mostly as, to use the Health Begins language, as a partner and a follower in communities and in partnership with our social services colleagues in the pre-hospital, pre-clinical, and sometimes that's post. But we also could be doing more inside in terms of reevaluating our own practices and making sure that we're doing better around whole person care. So I'm not sure if that'll be a satisfying answer, but in terms of the framework, I think it's sort of reinvigorated our team to say you can't you know, you can't just operate within what has traditionally been our own wheelhouse, that we have a role to play more in partnership with our communities. Len, I appreciate the clap. I saw that.
Thanks.
That's a Len Nichols answer.
Yes, I've heard those before, but it's a truthful answer. So we have one last question, and that is not from me. That's from Dr. Octavio Martinez. So Octavio, take it away and close.
Thanks, Elena. Thanks for a great presentation, Dr. Gottlieb. A quick question, because thinking about the different communities, like Elena was pointed out, and obviously culture, importance of that it plays, and language.
We're struggling to hear you.
Oh, yeah. Uh-oh.
California, like Houston, it's very diverse.
Octavio, we're not hearing you.
Dr. Martinez, you can enter it in the chat and we can read it.
That would be great.
So I haven't seen a chat come through from Octavio, but I'd like to, I know we're over our time. So I do have a question if we want to wait for Octavio, or we can just go ahead and move on to the next panel.
Let's give him a chance to submit it, and Eileen, ask yours, and then we'll
Okay.
let Laura off the hook.
A big question, but maybe you can keep it tight, is you mentioned the closed loop referrals. That process has not gone up and running. And to be honest, I think when we went into this whole project, we thought we'd find a lot more of that activity in Texas, and we're surprised to see that there wasn't very much. So my question to you is, what do you think, what are some of those key barriers that are keeping us from being able to get those closed loop referral systems up and running in communities?
I mean, Eileen, I think it'll be a good conversation. I can just highlight a couple of the things that we heard in our interviews that I think people, you know, have been sort of kind of the most obvious, but it hasn't been super easy to get the referral agencies, so the social service agency is on board with the technology that was, you know, purchased or developed by healthcare systems, and you know, in part that makes good sense. Like organizations outside of healthcare already have their own workflows and processes and technology systems, and so anything that wasn't co-created or that doesn't operate well with existing systems in the social services space it doesn't necessarily make sense for the social services, which are already, you know, often technology resources scarce, or have very limited staff or financial capacity to adopt new processes. So that's one. And then I think that you know, the second piece of it is probably there's a trust and a relationship part of this technology that is really foundational. So I think Yuri and Caroline spent a lot of time talking with people about that issue, that it doesn't, it's not just about technology and the ability to access the technology across different systems. It's also about, well, why would I feed that information back? And do we have a community of caregivers and it hasn't always felt that way, I think, to the social services sector. It's, you know, often kind of classically that the healthcare sector has used up all the dollars, and that the social services sector isn't necessarily getting paid for this work that they're now being asked to show or demonstrate back to the healthcare delivery system. So I think that those would be two things that I would start by highlighting, but I think that's a conversation. Does that help?
Yes, thanks. That's great. And that will be part of our conversation these next couple days.
Great. Well, I will be intermittently able to join for the rest of the afternoon. So if Dr. Martinez comes on and sends me a chat, or if anybody else wants to send a chat, I'm happy to do my best to respond in that venue. But it is so nice to see some of your faces, meet people that I've only emailed with before, and thank you again for including me in this conversation.
Thanks so much for joining us. And now we're going to move into a panel that Dr. Roxana Cruz is going to facilitate, and we'll hear from some people in the trenches. Thanks so much, Dr. Laura Gottlieb.